Hello, everybody. Welcome to today's webinar, 6 months till Emergency Preparedness Guidelines Implementation. Here today with Dr. Bob McKee from Boston University. I'm Lisa Johnston, your moderator for today. I am the Senior Program Manager for Healthcare. I've been with the healthcare industry for 4 years now, and I've been with Everbridge for just over a year. For those of you who've gone to some conferences in the last year or so, you might have run into me. I've been everywhere from the California Hospital Association to the Joint Commission conference last month in NOLA to HIMSS to the American Telemedicine Association. I'll be out on the road continuing into the next year, so hopefully I'll get a chance to see you if I haven't met you yet. So we just want to, set this up a little bit. So CMS has decided that we need emergency preparedness guidelines. They sent them out in the fall of 2016. The guidelines are already in place. It's something that you should be working through the process of implementing, but we do have a hard deadline of November 15th for this year. So you must have your drills done, your paperwork in place, plans together, everything ready to go. I know that there's been a little bit of complaint about the extra work that's being done, but the reason why they implemented the plans is because preparedness does matter. Just to give you some examples, we don't want to be in the situation where we're evacuating babies from a NICU like they were doing at Bellevue Hospital during Hurricane Sandy, or we want to be able to have all the processes in place to respond to something like the Orlando nightclub shooting. The picture that just came up on the screen is the Cajun Navy, which was a group of citizens who stepped in to help rescue down in Louisiana last summer. And then, of course, pandemics and epidemics. The picture that you're seeing is from Emory University when they were bringing one of the doctors back from West Africa with Ebola. So we want to be prepared for that. The other reason is that there is some financial risk as well. There's penalties that are involved for hospitals, nursing facilities, HHAs. Payments could be suspended or reduced. There could be charges per instance or charges per day. So this is altruistic in nature. We're really looking to keep facilities open and keep patients safe, but there is a financial risk as well. Before I introduce Bob, we just want to cover the 6 areas that CMS is looking for us to prepare for. There's pandemic, epidemic, biological threat, chemical threat, nuclear, fire and incendiary, and natural disasters. So with that, I'd like to introduce Bob. Hello.
Hello, how are you?
I'm honored today because Bob is actually sitting next to me. So Bob has over 30 years of experience in fire, emergency management, disaster preparedness, and crisis planning. Just to give you a couple of quick highlights, he was involved in disaster response teams that included the World Trade Center on 9/11, the Space Shuttle Columbia disaster, Hurricanes Katrina and Ike, and the Haiti earthquake response, just to highlight a few. Hello.
Hello.
So with that, I'm going to send it on over to you.
Absolutely. So as we look at where we are today, so it's a humble Tuesday, we're thinking about CMS, and we awaken to say, oh my gosh, 6 months to go. So it's quite challenging to think about all that we have to do, all that we need to prepare for in that period of time. So with all that we have ahead of us, 6 months, November 16th, unbelievable. Are we prepared? So what we've done is put together an overview of the CMS rule in the research support and the information support that we have partnered with Everbridge through our program at Boston University, Healthcare Emergency Management Program. A number of our students have been involved and our staff to try to provide the practical operational aspect of what does this mean. We all deal with regulations, we all deal with necessities, but in this particular case, although there was an extensive comment period that CMS offered, the number of comments that came back and the complexity of some of those questions, I'm sure in your mind, still there are a number that have yet to be addressed. So the final rule, we're looking at the comprehensive, consistent, flexible, and dynamic regulatory approach to emergency preparedness. As we look at those, we're looking at them in different contexts. So it's not just the hospital structure, but it's 17 unique provider types that are affected by this particular rule. I'm sure many of you are very familiar with the rule and you've probably been at work, but I don't want to make any particular assumptions. So I'm going to cover some material that may be repetitive, but it's to provide a good basis so that at least terms, the definitions, and the point of reference of which we make, we're all speaking from the same sheet of music. The final rule addressed three key areas, and that's safeguarding human resources, maintaining business continuity, and protecting physical resources. Within those areas, there were four key elements that we'll see throughout, and that is the risk assessment and emergency preparedness through an all hazards approach. It's going to deal with alarm and notification systems if that's not already part of your plan, and policy and procedures, which are different than operating guidelines. We're going to ensure the successful execution of the emergency plan, and we're going to do that through various means of training and continual testing. The staff and patient client tracking during and after an event come into play. Our communication plans are very important. We have to have a strong emphasis on patient care and contact with the physicians and key staff. While we do that to some degree currently, the rule requires that we go further, and in some cases that we actually receive a positive response. So it's not just a matter of saying that we need a key nursing staff to attend an event, but we must, in this particular case, have positive confirmation. And then certainly the medical records, so that as we're looking at potential patient transfers or handoffs, we have to do that according to HIPAA and all other regulatory standards so that we don't violate patient rights or any of the care protocols. Training and testing is an area that's probably had the greatest amount of questions because, again, there have been some terms used that I'll discuss a little bit further that maybe they're not clear to the entire community. We're going to do not only initial but ongoing training. The key word within the rule under the training and testing is knowledge. We have to have the knowledge. And the drills need to follow the HCEP guideline, which is the Homeland Security Exercise and Evaluation Program. There's a plethora of resources available through FEMA that discuss the HCEP process, but at first blush, it can be overwhelming. So as we discussed today, if you have any questions, please let us know. So breaking out those four core elements a little bit further, the risk and emergency planning element is for us important because we must assess and develop an integrated all hazards approach that addresses those capabilities that are critical in a crisis situation, that include patient accountability, alarm notification systems, our available capacities, and this plan must be reviewed and updated annually. And I underline that because it's a key factor and it is certainly mentioned specifically within the CMS rule itself. The policies and procedures, we must develop and implement policies and procedures that support the risk assessment, emergency plan, and communication plan. These policies are going to ensure and going to be the measure in which that the system of systems that we put into place are going to track all on-duty staff, any of the sheltered patients or clients during and after a crisis event. You'll see again that I've highlighted and underlined two particular words. Those are core elements within the definition of our primary core elements. The communication plan, we must develop and maintain an emergency communication plan that complies with all state and federal law. This incorporates contact information for other healthcare providers. So if for some reason we're going to transfer patients, if we're going to rely on a healthcare consortium, we must have all of that information listed within the emergency plan and the communications plan. We have to make assurances that the method for sharing this information and medical documentation within and amongst the providers is in accordance with HIPAA and all pertinent rules and regulations. Attention should be particularly given to the patient care occupancy throughout the facility and with any transport of patients. So again, it may seem as though an obvious statement, but when we need to transfer patients during a disaster or a crisis event, we must have those things in place well in advance because of the complexity that we have, not only with the physical move and the obvious aspects, but the sublime aspects that are going to creep up, and certainly as the incident or the disaster continue to be chaotic and continue to be dynamic, we need to plan for as much of that as we can prior to the event. Training and testing, we want to develop and maintain a training and testing program for all new and existing employees. All employees must demonstrate knowledge of emergency procedures, evacuation routes and locations, and patient instructions. The rule specifies that annually a full-scale facility or community-based exercise must occur, and an additional exercise of the facility's choice may also be included annually. I'm going to talk about this a little bit more in detail in a couple of slides, as one of the question points that has been raised offline with a number of individuals has been, tell me a little bit more about what a community-based exercise might consist of. The rule is specifically addressed and geared toward 17 different provider and supplier types, and they're listed here as well as through the CMS frequently asked questions and several documents. And again, one of the comments or one of the feedbacks is that there are a number of provider and supplier types listed that previously had no requirement for any type of plan. More than likely, those facilities or those organizations had a plan. However, in this particular case, they are listed that they must comply. So again, we'll talk about that a little bit further, because even though we may have an ambulatory surgical center that's part of a main hospital, if the hospital is in compliance, does that mean that the ambulatory surgical center is immediately in compliance? And I'll go into further, but the answer initially is no. It's based on that facility structure. It's based on that facility. So again, we've talked about this, but you can see that Lisa and I intend to make it very clear that the effective date for this is the 15th of November, 2017. We've had a year in which to review the comments, to look at various sections. Other accrediting organizations certainly may exceed CMS. Joint Commission has, obviously, as many of you know, has been involved in emergency preparedness through their rule and guidance set. They are looking at this issue. We're very well aware of that. They're looking at the CMS. They're looking at what are the parallels, are there any gaps? And obviously, these organizations want to work together so that there's not a great deal of duplicity, but more in a supportive nature to say, let's make sure everyone's prepared, main goal. Let's make sure the patients are properly addressed, main goal. Secondary goal is, let's see if we can make this seamless across the systems. Alternate sources of energy, power generation, backup, emergency lighting, fire detection, and extinguishing systems are key into some of those 17 provider types, which have never been significant. So the involvement of your local community, your emergency services, police, fire, emergency medical, emergency management are really going to matter in this preparation for both forming your plan and then the annual evaluation of your plan. What if my organization says, I've seen this before, CMS is a fleeting theory, we'll just see how the chips fall. Very clearly in the rule, no exceptions will be granted for the requirements of CMS. Non-compliance will follow the same procedures as non-compliance with any other conditions of participation or conditions for coverage. The challenge, obviously, as Lisa preempted in the early slides, is the fact that we are potentially significant financial burden if compliance is not in the appropriate space. So it's about the planning, it's about the actions, it's about what we can do and should do. Until the rule is in full swing, we're not really going to have anything to draw upon of what the inspectors are going to be looking at, what kind of research and material they're going to be using. But until that happens, we need to make that preparation as earnest as possible. One of the helpful tables that we've used in a number of our presentations actually comes from the ASPR, the Assistant Secretary for Preparedness and Response, that helps us look at the provider type, the emergency plan, and then each of those four core elements that I discussed earlier. So the emergency plan, policies and procedures, communications plan, training and testing. And then any additional requirements or notes, if you will, that are specific. These are available on the ASPR site, but we will also make the slides available. So please take a look at these in depth and look at your particular facility. Look at where you are, what you need to be doing, and what support and assistance that you can gain in those particular areas. Again, you'll see that some facilities that have had to have a plan in the past are listed, but some that have not been required. The freestanding facilities, the home health care agencies, the acute clinics, these are facilities that we want to make sure have all of the information necessary. So let's talk about what additional considerations are key into this. We know the clock is ticking. We know that we've got this bit of a worry in the pit of our stomach, but what can we do? And so some of the feedback that we've received in communicating with a number of constituents is the fact that the clarity, if you will, on some of these terms. So what we've tried to do in this case is to just put these in kind of a hints section, if you will, and talk about them for a few minutes today. So an active community-oriented drill. What is this? There is no definition. We can look at Merriam-Webster. We can look at we can Google till our heart's desire, and there's no clear definition of what this is. However, in context, what it is it's a drill that you are indeed interacting with your community. And the community is defined as not only those responders that are going to provide you assistance, so the city, the region, or the state, as well as police, fire, emergency medical, and emergency management, but also your community of constituents. So any particular organizations, any particular activities that you would have. And most organizations are going to have a robust plan to communicate with their community. It may include social media, it may include website updates, it may include the use of the Everbridge platform. And in that particular case, those are all inclusive and all important in that community-oriented drill. So in this particular case, as you decide what the measurements, what the injects, what your master sequence of events list will look like, include the community, ask them to be a part of it. That it may be something as small as a beaker, a fluid, a chemical spill in the laboratory or in the laboratory pickup area. But as we've all seen on the news, small events can very quickly become big events. So how can we work together as a community in not only the practical mitigation of that particular incident, but even in today's day and age, even more importantly, is that communication. So what can we do? How can we communicate? How can we use social media, our website? How can we use our relationships, our contacts to ensure the community is aware of what we're doing? Another question that's been posed are, what are the penalty levels that we can expect? While there's been some examples, again, it goes back to how it will impact the particular COPs, for instance, and how they will in fact be rated. So we don't necessarily have a definitive answer to that. However, we know that there will be penalties, there could be penalties, and they could be significant. So we need to understand that this is not an optional decision that we can make as an organization. Is there a preferred plan template? No, there's not. The realistic approach of the CMS rule, and as many of you have dealt with Joint Commission visits and accreditations, the plan needs to be what fits your organization. It needs to be the best plan for your organization. There are so many different templates and so many different types, but as long as the information and the function is a part of that plan, those are the core elements. It's not necessarily whether it's in Word or Pages or it's PDF or it's electronic. It's the plan that best serves your organization. The other key factor is rely upon your local emergency response connections. I've said it a few times, but it begs to say again and again, and that is that as you study and worry about this particular rule, so are your emergency response partners. I've discussed this with a number of police and fire and EMS providers, emergency managers within the community in the region, and they're saying, what can we do? And in a number of cases, I would say the majority of them have not heard from their local or regional healthcare partners. So we need to make that partnership. We need to work with the people that are dealing with this all the time, so that as you begin to address, for instance, we're going to do just a local exercise, have the individuals that must do this on a regular basis come in to support you. They're willing to help you. And then healthcare coalitions. I'm going to go into a little bit more detail on the next slides. This has been a very, very popular question. So how do healthcare coalitions fit into this? So specifically within the rule, healthcare consortiums should expect the covered healthcare facilities to contact them in asking for assistance. So some of the guidance that CMS themselves have provided is to provide a hazard vulnerability analysis or a risk assessment within that consortium, so that how can we rely upon one another and how can we turn weaknesses into strengths? What are some of the examples of plans, policies, and procedures that are frequently used and other entities are accepting these within their coalition? So back to the point, what is the plan template? Well, if you're a part of a healthcare coalition, ask your coalition members, what are you using? What does it look like? Is there value in us having a same template? These are important discussion items. Engage in training and exercises that are conducted with and for the coalition members. We can do this alone, and again, in some cases, we need to understand how our internal agency or internal facility is going to operate, but in most cases, if it's anything beyond the basic type of crisis or disaster, it's very quickly going to spill out into our coalition members and to the local community or the greater community as a whole. So involve our coalition members so that we indeed can work together. We want to explore participation in and leveraging on shared services, such as communication systems, patient tracking, and other jointly used equipment supplies. There will be, again, an ebb and a flow within any crisis situation, as many of you know, but how can we rely upon the consortium as opposed to us being on an island of our own facility? That is a recipe for disaster. Providing basic information on emergency preparedness and healthcare systems preparedness. Share ideas. So let's get together as a consortium. Hey, how are you addressing this particular issue? You know, what about the pandemic? What about the inside attack? What about these particular situations? How are you addressing them? What are those elements that you've explored? That is serious value. So please use the healthcare consortiums. And then providing any technical assistance support that you may need to help support the rule itself. Technical assistance is a very big and broad word, but in that particular case, the assistance is, let's talk about that, let's look at, and obviously each of our organizations have subject matter experts, whether it be communication systems and IT, whether it be operational protocols or particular response realms. Let's rely on one another to address these issues. I hope these items have been able to, again, just bring this issue back to the forefront. We want to make sure that it's not something that just waits and waits and waits. Everbridge and Boston University Healthcare Emergency Management Program are here to help you and here to provide any assistance that we may. We have partners, we have coalitions that we continue to talk with and work with. So essentially, you're not in this alone, and neither are we. At the end, our goal is to prepare for that tragic event, how big or how small, and to most in particularly make sure that our patients, our clients are taken care of, their family members are communicated with, and each of us are able to rest well knowing that we've done all that we can. Thank you, Lisa.
Thank you, Bob. That was great. It's so different when you're in the room with me.
Yes, ma'am.
We did get a number of questions in already. We have more than a handful that we're going to be working through. However, now is a great time to add your question to the queue as well. So one of the things we think about is when a crisis happens, what do you need? What are the things that you have to do? And probably the first thing you have to do is assess, is this a big incident or a small incident? How many people do I need to pull into it to resolve it? We also talk about locating. You're going to need your critical staff and your vendors. Might be facilities, security, clinical. Maybe you need to get a hold of the blood bank. Knowing that your energy supply is running through the hospital, maybe you need an outside contractor to make sure that that's happening. And you need to act. You need to, implement your command center, start going through your checklist, make sure that things are getting done in a timely manner. And then you need to work outside of the hospital, and you need to communicate and collaborate with those people. I have to say, I purposely put a picture of microphones up there for a press conference, because I think that perhaps strikes fear more than anything else in an emergency planner's heart. Do you have a PR plan? Do you have something in place to speak to the press or put them in a certain area so they're out of the way, but still, communicating with the outside world? Everbridge can help you do all of those things. we can help you run your command center like we did a couple weeks ago with Seton Medicare facility in Austin, Texas. And we can run mobily. You don't have to be at a big table with a lot of computers. We had one emergency planner on vacation in a canoe who ran his entire incident off of his mobile phone, and everything turned out fine. You do need to reach that local community, as Bob stressed today. It's very important that you're working with all of the parties outside of the hospital walls to ensure safety and security. And you also really need to think about your community. Do you need to speak to people in different languages? Are there specific ethnic groups that you need to approach in a certain way? So you need to think about, that 1% of your community and how you're going to keep those people safe along with everybody else. As I mentioned earlier, we do have the CMS Emergency Preparedness Library. We'll send that out to you as one of our resources. And we also have the Everbridge General Hospital Test Facility. We have a bundle of templates for CMS. We also have a whole array of HICS forms. So you can go in and execute an incident, see how it works. You can look at our logging system, our response system, so you can see how all of that works for you. Okay, so with that, I'm just going to let everyone know my contact information is down at the bottom, lisa.johnson@everbridge.com. If you have any follow-up questions, please do. And with that, we're going to go to our first question. This was actually asked by email before the start, and he was quite anxious for an answer.
Okay.
So Tim, this is for you. He's reading the CMS protocols, and he's like, is this more of a protocol or is this more of a policy? And it makes a difference for him, because if it's a policy change in his hospital, then he has to go through an entire approval process. If it's more procedures and checklists, then he doesn't.
I would answer that question that the interpretation of the rule in our study was that it was in fact specified that this is a policy and a procedure, and if you go back and look at the slides, and I hope you'll take those as a reference point, is that in parentheses it says this is not an operational guideline. In this particular case, it is a rule, it is a CFR, so in that particular case, most correlations deal with policies in that particular case. And with all of the experience that I've had in the past, that is going to be very onerous, it's going to be very difficult, it's going to be pushing against a very, very large rock. However, to have a policy that very specifically states and empowers those necessary to ensure an emergency plan, a communications plan, a training plan, etc., are in place, may be a better option.
Thank you very much. That was very thorough. And then from Mark, are clinics and ambulatory care occupancies required to do a full-scale exercise?
The best point of reference is that blue chart that we pointed to you. And in all cases, the training crosses all barriers. So we need to train both new and existing employees, and we need to do exercises. The number and the periodicity of the exercises is different by each provider type. So I would point you back to that chart specifically, because one of the research points that we found was that although I may call myself a freestanding rehabilitation facility, you need to look at the definition to make sure that that's what you refer to it as, or your organization, but what does CMS refer to it as? So I would suggest, one, verify your provider type, and then look specifically at the requirements.
Thank you. We got about 3 or 4 different questions all grouped around the same idea, which is if you have multiple facilities that you are responsible for, how does CMS want you to set up the planning? So do you need to do an active drill at every facility separately? Can you put some under the umbrella of another one? We literally got notices everything from a dental van to critical access hospitals. So how does that work out?
There is no definitive answer. I'll qualify that. But that is a question that has been posed on a number of occasions. Again, I'm going to rely upon my experience to answer this question, and that is that per the CMS rule, they will be looking at the facility. So if you're a facility, again, a rehabilitation facility, a home healthcare facility that's part of a hospital system or a healthcare system, CMS is going to look at your facility first and then the organization second. The best way to address that would be, as you do exercises, make sure that all of your facilities that must be in compliance are included in the exercise. So that you may do one exercise that includes 4 facilities, but you're getting credit for each one of those facilities. They just need to be unique to make sure that it's not just a tertiary, yes, I was notified that there was an event at the hospital. No, there needs to be some sort of a tasking or some sort of a documented measure of exercise, so to speak. But if that is in fact the case, and it's realistic to what that facility is, a home health care agency, for instance, maybe it's a staff call. The hospital needs 10 nurses immediately, and they've made that contact. You've gone through your contact list, you've identified the 10, boom. The home health care agency just completed that activity as part of the exercise, and the hospital just completed that exercise. So even though it's one exercise, in truth, you've each exercised your facility.
Yep. And just to add to that, while you were talking, like the example that was coming to mind is if you're in a flood zone and you have an HHA that you need to work with, that those people you could do an active drill where there's an evacuation to the hospital for care, or perhaps some other type of bed matching where maybe they're not going to the large hospital, they're going to a smaller facility. So that's something that you could map out that CMS would be very happy to see. That happens on a somewhat regular basis these days with floodwaters. Absolutely.
And the critical access hospitals is a particular topic. One of our master's students is doing a thesis on the subject as we speak, and I've just been fascinated to learn the complexities of the critical access hospitals. So that's certainly a much broader issue.
Yeah, I definitely want to get into bed matching more. It's so important. We will be doing a webinar in the future on bed matching. So for the second exercise, the tabletop exercise, how large does it need to be, and how many departments does it need to involve?
Again, you will not find a specific answer in CMS. So I preface it with this is based upon experience. A tabletop exercise is an exercise that allows stakeholders to come together. So whether it's department heads, whether it's department managers, it needs to be at the right level. But a tabletop exercise is a great way to stress the system. So what are those things that are going to stress your system? Maybe it's something such as notifying employees that we've had a snow emergency, so the only people that need to show up today are critical, those employees that are identified as critical to the operation. What if it's something as unfortunate as the death of an employee? How would we make notification? While that doesn't necessarily require a response, it does require a very careful communication. So what are all of those entities within that event, that stressful event, that physically and emotionally stresses the facility? What are those things that you would identify? So as professionals, I would suggest, what are the items that keep you awake at night? What are the things that you really, really worry about? And then pull those subjects together, put a planning team together. Once you have the event in mind, then who attends will become a natural second hat.
Thank you. There's one quick question here, and it's about the IGs, the interpretive guidance, that's going to be coming out soon. And the question is, when is it coming out? You can give me your 2 cents, but I can tell you the rumor mill, and it is a rumor, is that it's going to be this month. I did have an individual tell me point blank that it was absolutely coming out this month. It was not somebody in CMS, so do take that with a grain of salt. What have you heard?
I have heard just about everything from May of 2017 to May of 2020, all kidding aside. However, the most common answer that I have seen, read, heard is that the guidance will be released by the summer. So I think that's certainly in line with what you've heard, Lisa, that if it's this month, but I have heard by summer. So
we have to start wearing white after next weekend.
That's
so
right.
I think we're there. Have not gotten this question before. I'm pretty sure I know the answer, but can the annual training be done online or must it be in a physical classroom setting? I'm assuming they're referring only to the tabletop.
Well, the online training, again, now you're into our particular wheelhouse at the Healthcare Emergency Management Program at Boston University. The pedagogical model of which we deliver training is not necessarily as important as it is the objectives of the training. So if you can accomplish the objectives of the training through an online platform, you've met the objectives. If it requires face-to-face, then you must do the face-to-face. So it may be, for instance, if it's a specific training event, that's going to be quite clear. But it may be that, just as Lisa mentioned, an individual activating their emergency plan from a kayak, that's real world. And, whether that was planned or unplanned, I actually smiled when she shared that because I thought that was very creative. We all have lives, and while most of us feel like we're at work a lot, in most cases, we have to be able to be mobile in today's society with today's technology. So using online training is in no way prohibited, but just make sure that it maps back to the objectives and that you're meeting the objectives, whether it's face-to-face delivery, online, or it may even be a hybrid delivery.
And we've got two more questions. We could probably sneak in a third, so if there's something you're dying to know, ask it now. So what about cyber threats? We just had the incident with the National Health in the UK a couple of weeks ago. That definitely rattled some cages. How should we be thinking about cyber threats?
Cyber threats are real. This is an issue that I believe that we need to continue to discuss, we need to continue to explore, because it's not calling the IT help desk and saying, hey, my email doesn't work. A cybersecurity threat is very sophisticated, and imagine, if you will, that everything that you needed access to, including electronic medical records, including any of your security systems, which are traditionally monitored. Imagine if you were unplugged and what chaos that would more than likely provide. Couple that with a power outage, for instance. What could you really accomplish? Could you even transfer patients if you had to? What if your main PBX system goes down? These are all actionable items. However, they're all related to cybersecurity, because most of the phone systems that we're on now are voice over IP systems. So they are on the internet, they are out there. So we can build our firewalls very deep and very high, but cybersecurity is something that we need to ask that question. And we need to have some sort of a plan for, if you will, that doomsday scenario of how do we simply get patient accountability and employee accountability if we have 7 or 8 facilities in a region or across the United States.
And I would add, I don't know if you guys are on their email list, but the weekend that it was happening, we were seeing that Health and Human Services was in the lead for the cyber response, not CMS. CMS did send out an email, but I think even one of their links went back to HHS. So it'll be interesting to see if in a year or two they add that to the emergency preparedness guidelines. But right now, it's not one of the 6 areas identified, but you're supposed to look at a risk assessment for your hospital and do what's there.
Exactly, and I think that goes back to the slide that we talked about healthcare coalitions and the risk vulnerability. So do your hazard assessment, do your risk vulnerability, and if you think that it's an issue, look at that. Where's your data stored? Is it on-site or off-site? But being proactive is certainly something that we all need to encompass into these plans.
Okay. And then our last question for today, somebody is doing an active shooter exercise. It's going to be at their main campus, but specifically held in the SNF department. Will this exercise count for clinic facilities if they will be participating in the exercise? So,
the way in which the question is posed, it sounds like yes, indeed it would, because your clinical facilities are included. The key here, I think we'll all agree, is documentation. So make sure that there's a robust outline, a master sequence of events list or a measle. Make sure that we're following the exercise protocols. And if we have that documentation that you can show that we have this event, these are the actions, these are the participants involved, I certainly see that would be included and credit would be given for those facilities.
And that's going to do it for today. Thank you so much, Bob, for joining us and the excellent information as always.
Well, thank you for hosting it, and I just wish everyone the very best of luck, and please stay in contact with Lisa or I or any of our partners, and good luck with this process.
Yep. And until then, we will see you soon. Thank you so much. Bye-bye.